Well, good afternoon. Everybody going to have a sugar droop? Did you make sure you took care of that before you came in today? This is my bad time of the day, too. I'm glad I'm standing up, not sitting down up there. We're so glad to have you here. I'm Elaine Bailey. I'm with the Department of Social Services. My job title is Team Leader for Region 1 in the Upstate, which is a regional position responsible for child welfare activities. I'm also the director at Oconee County DSS. And some of you folks I recognize. Hey, I just saw you sitting there. And some of you I don't, but we're really glad to have you here this afternoon to learn more about our community-based prevention services. You may have heard this referred to previously as appropriate response, and we'll talk a little bit about why we're making the more descriptive name change this afternoon as well.
This is going to drive me crazy. And I'm Steve Strom. I'm with DSS also, and I am the, they call me a senior consultant. I basically work with any of our programs that we're implementing, new programs that we're implementing. So I'm, Jessica calls me the NERM guy, which is too close to the nerd guy, so I try to stay away from that. But I try to work with the implementation and get all our programs up and running and get them going and keep them going and make sure we're doing them with fidelity. And I'm going to let Elaine take it back.
You're going to get jerked back, and I'm going to trip and fall, so it'll be fun either way. Right. There's a common misperception in the state of South Carolina that the people that are responsible for child welfare are the people at the Department of Social Services. And that is a misperception. The people of the Department of Social Services are part of the system of care that is responsible for ensuring children's welfare. We are all responsible for children's welfare. Our communities are responsible for children's welfare. And the community is much better equipped to take care of children's welfare than any of us are, because they see those children all the time in different settings at different times of the day with different people, and they can really see what's happening with children. And we have got to get the community invested in being part of the process of protecting children, because I've only got two eyes. I can only see so much. So we're going to talk today about ways that DSS is reaching out to the community to get more folks involved in ensuring the welfare of children. And the comment here is it's like saying that DSS is responsible for child welfare. It's like saying doctors are the only ones responsible for people's health. We are all responsible for our own health and for the health of the people that we love that are around us. Communities are the places where we can take action to ensure welfare of children. Children belong to the community. They interact with the community. We talk, and we have to educate our own staff about this. DSS, when we open a case on a family, when we start working with a family, we don't own that case. We can't do the work for the family. The family has to do their own work to keep their children safe. And the only way we can help support the family in doing that is to get the folks around the family to be engaged in part of the process. So we are just one of the agencies responsible for building protective capacity and providing protective factors. Why do we need to change? I'm going to let Steve talk a little bit about this.
The reason we've made this change is, as you can see, well, for a while there, you know, when you called DSS, you made a report. We either took it or we didn't. And if we didn't, that was it. So it didn't go anywhere else. And if we did, then we went out and did an investigation. What we were finding is that, if you can see here that we were only finding abuse and neglect. We'd go out and do a lot of investigations, but we were only finding abuse and neglect in 36% of the cases. So that meant in 64% of the cases, we were going out and doing a lot of work, and there was nothing there. There was not enough to rise to the level of abuse and neglect. So we were spinning our wheels a lot of times. We were using a lot of staff time, a lot of staff energy, knocking on people's doors. You know, people love to have us come to your door, right? That's who you want to see come to your door is DSS, right? I mean, you know, so I'm from the government. I'm here to help you. So, yeah, that's right.
Immediately increase the stress level in families by knocking on their door. And then we start nosing around, asking a million questions, saying, oh, there wasn't anything there.
Right. So if they weren't abusing their kids, we probably raised the stress level enough that they might be. But anyway, so or if they weren't using drugs and alcohol, we probably made them want to use drug and alcohol because we're knocking on their door. So as you can see, we're spending a lot of staff time, a lot of energy, intruding on families we didn't need to be intruding on, and so it just wasn't working. And so we needed to do something different, and so we have tried to do something different. And I want you to remember that figure of 64%. In a minute, I'm going to tell you why. So So when we're doing an investigation, we could make referrals. We could say, hey, you know, we think you need to go here or there or whatever, but there was really no case management after the 45 days if we unfounded a case. So in that 64% of the time, we would say, you know, hey, maybe you need to go here or there or whatever, and we'll help you as much as we can, but you're doing seeing a lot of other folks that are that you're spinning your wheels trying to make those referrals, so there's no case management. And it also means that as we're working on those cases, the real severe cases are not getting taken care of. So we're spending a lot of time not taking care of cases we really should be. A lot of times there were risk factors within those cases. We would go out there and we would see risk in the family. I mean, every family has risk, right? I mean, you drive on 26 or 77 or any of the, you know, that's risk, right? So, so every family has risk, but there were some that were a little higher than others, some that were lower, but you would see risk. And we got put in that ethical dilemma of sometimes families really needed services. There wasn't abuse and neglect. But what do you do if you know a family needs services and you don't have the manpower really to case manage that case in the 45 days? So we only have 45 days during investigation time to make a decision. Then what do? Do you indicate a case just to get services? And that is a really bad place to be. You don't want to be where you're indicating cases just to get services. And the reason I wanted you to remember that 64%, our indication rate, as you saw, was down in the 30s. Since we've started the community-based prevention services, and especially in the upstate, because that's where we rolled out first, in the Anderson, Greenville, Spartanburg area. Right now, our indication rate is at 61%. So if you think that 64% of the time, you know, it works out that we're now seeing the cases that we need to see, and our community providers which are in the room, are taking care of these risk cases, and so we're able to see the cases we need to see and indicate the cases we need to indicate, and our indication rates have continued to rise as we've gone through in each region. The way we roll this out was different regions of the state, and you can kind of watch the progression of implementation as you go through. The next one is rising, the indication rate's rising, then the next one's starting to rise, and the next one's starting to rise. So now we've gone from a 36% statewide to about a 54% statewide, and getting higher and higher. So that's one statistic that makes me think that this is really starting to work.
And I'm feeling like we need to kind of make sure that everybody's in the same place, because some of you are actually our providers in providing this service. And while the slides talk about the theory behind what we're doing, what we've actually done, for those of you who don't know, is that DSS has created contracts now with community agencies, and the agencies, we have master contractors who have gone out and reached out to local community agencies to create a network of providers, where instead of when we receive a case at report where we do not see that a child is at risk of harm, that there's not a safety issue, that there's not moderate risk, that something could turn into a high risk or something could turn into a safety issue, we have the ability now to refer that case to someone else instead of just screening it out and doing nothing. We can say, we don't see abuse or neglect, but we do have concerns. We're worried about this family. So now we have the ability to refer that case over to our network of providers. And providers who are in the room, y'all hold your hands up for a minute. There we go. Okay, we have a variety of folks from across the state. And these folks then can go out and assess the family and determine what kinds of services does this family need to strengthen the way it functions in order to make sure that children are protected. It's a prevention service as opposed to DSS, which is an intervention. Okay. And when we first started this program, it was called Appropriate Response because we felt like this ensured that every family had an appropriate response. And then we realized that it was confusing people because there's old language out there about alternative response, and it didn't sound very clear. So we've recently tried to clarify what this service really is, that these are community-based prevention services. Not driven by DSS, but driven by local providers, a network of providers in our local communities. Okay, so that may help for those of you who weren't up to speed on what was going on with what those changes mean. Okay. Back up. Okay.
You give a man a remote, right?
Okay. Okay. Things that we do know, and I think that all of you probably know about childhood abuse and neglect. It happens in every stratum of our society. It happens in every part of our state. It happens in every community in our state. Even though there's an association between poverty and the possibility of neglect, the reality is that child abuse and neglect can happen to anyone, anywhere, to anybody's family, to even a healthy family if it begins experiencing significant stress or something happens, economic factors change. It can happen to anyone. There's no one single identifiable cause of maltreatment. We associate substance abuse with one of the high risk factors, but there's so many other factors that can cause a family to fall into patterns of abusive and neglectful behavior. There's no one thing that's happening out there. Okay. What we do know about families is that even though they're all subject to the same stressors that may lead to abuse and neglect, the families that are more successful are those that have protective factors. And I'm going to let you address some of those.
So one of the things that we want to do is build protective factors in the communities that children live. Go ahead. Right. So we know that children under 5 are the most vulnerable, right? Because they are the ones that aren't seen, that sometimes are at home or not in school, whatever, so there's not as many eyes on them. We know that children over the 0 to 1 are the ones most likely to die from abuse and neglect because of shaken baby, all those things that go on like that. We're hoping to get a campaign going where we do some public service announcements or some stuff with Children's Trust about the boyfriends or paramours of where these folks are leaving. I mean, these women are leaving, usually women leaving their babies with men that are not the biological father, and a lot of times that, because they're not as bonded to that child, there's a lot of times either severe injury or death from that kind of stuff. So we're going to start looking at that also. This you got the pointer. This next point is very important, and because a lot of people think, well, let's just put them all in foster care. If we see abuse or neglect, let's put them in foster care. Then they won't be abused or neglected, hopefully, which is kind of a myth too, because that can happen in foster home placements and group homes just as well. But most of the time they're safer in foster care. So, but the trauma of being abused or neglected is dramatically compounded by removal from families at this developmental stage. So you're actually, when you remove a child, you've got to make sure that you really need to remove that child from that home, because you are really increasing the trauma on that child if you remove them. And I know that people don't think about that when they think about an abused child. It gets that emotional reaction of, let's just get them all out of there. But we got to do, you know, in physician terms, do no harm. We don't want to harm the child more by doing something that's with good intentions, instead of doing the right thing for the children. So I definitely want people to remember, if you don't remember anything else today, remember that. Okay, so, and of course, we know that trauma has a cascading effect on development, and that young children are the most vulnerable for attachment, that kind of stuff. That's pretty much, okay? All right, all right. Some of what Elaine was already talking about. Risk is not predictive. In other words, you can have drugs and alcohol in the family, but if you've got a protector in that home, then a lot of times there is not, I mean, you would say that's a high-risk family. Somebody, I mean, a friend of mine that I grew up with, her dad was a horrible alcoholic. He was a functional alcoholic. He worked every day. But when he got home, he got drunk as sin, as my mama used to say. But he would get drunk every night, and all but her mother was a protector, and her mother kept her safe. So the fact that he came home every night and got drunk, yeah, that's a high risk factor, right? I mean, you'd think a lot of bad things can happen in that situation. But because her mother was so protective, it didn't happen, and she grew up and had a great life. I mean, she's a whole lot smarter than me and doing a lot more than me, but anyway. So you can't just say because of one thing, what Elaine was saying, you can't just say because there's this one risk factor that this is going to impact his family negatively. It may impact the family, but the child can be protected and be safe and still be in the home.
And not experience the trauma of having to leave the home.
Right.
Because of father's behavior.
Right. So there are 5 community protective factors, and hopefully, I mean, so we're going to talk a little bit about the protective factors that are tied to abuse and neglect, and these are community protective factors that we want to build in each community. We would like to see every community have these protective factors in place so that it would prevent child abuse. We can do a lot in our communities to prevent child abuse, and again, that's why we're with our community partners and our contract partners to develop those protective factors within the community and get families before abuse and neglect happens to those folks that can increase the protective factors, which hopefully will keep abuse and neglect from happening so we never have to deal with those families again. And of course, protective factors, we don't give families enough, and children, they're resilient. A lot of times they can bounce back from a lot of different bad things. We had a case one time where mom said, you know, I am God, she killed her son, she killed herself and told her daughter when she'd be back in 3 days. Guess what? She wasn't back in 3 days. So everybody thought that this child was going to be, you know, very traumatized, and yeah, it was a really bad situation. But the child was so resilient, she bounced back, and we tried to make her sicker than, a lot of people tried to make her sicker than she was just because she had seen so much trauma. But she was so resilient and had the resilient factors that she was able to bounce back and not have to go through a lot of stuff that we wanted to try to make her go through, because we thought, you know, as adults, we thought, hey, you ought to be really sick. So what we're trying to do is build a protective factor framework in the communities and around our cases, all right? So we need to, and this is what we're doing. We're mobilizing our partners and getting everybody together to. Now, the protective factors are And if you came to the conference, I see one pin there. From the last conference in April, they had the pins, I think, with the protective factors in them, so you could click them and they would, I don't know if any of y'all were there, we got them. So, the knowledge of parenting and child and youth development, and I was talking with Jane here a little while ago, and there's some exciting things going on within the state that's going to help spread that out so that we can get more of that going. Parental resilience, social connections, making sure that people aren't isolated. You know, isolation is one of the worst places to be because you feel like you're the only one that's having this problem and all that. And a lot of times there's other people having the same problem. And the more you can get folks together, they can figure out ways to solve those problems. We're also big on family engagement and family coming together to build a safety net. And if you're isolated, you can't do that. If you've got your family connections and you get those families together, many times they can come up with solutions. And that's why that slide was there about the families own the case. We in DSS have often taken the stance that we own the case, and we've been the hardest working people in the room. And if we're the hardest working people in the room, nothing's going to happen, nothing's going to change. I used to do marriage and family counseling, and there were times that I realized that I was the hardest working person in the room as the counselor, and they didn't really care. And when I realized that, I was, this isn't right. If they, I shouldn't be trying to work to save your marriage if you don't care, right? So, and it's the same way with us. I mean, the family owns the case. They need to figure out what they're going to do to keep their children safe. So, concrete supports, social connections and concrete supports. Sometimes it's just, I need a light bill paid, or I need diapers, or I need milk, or I need something for my children, or I need some food just to get through this. And so that's, again, something that our community partners are able to do to help us. And then understanding the developmental stages of children, which again, and Jane and I talked about that a good bit before this, knowing what's supposed to happen in developmental stages and knowing what's abnormal, and then being able to get, if you've got the normal development, how do you parent a normal child? And is that behavior they're showing, is that normal? Is that 2-year-old acting out, throwing a tantrum normal? And so that's why we need to make sure that people know what is normal, how you can parent that, how you can discipline at that stage that's going to be effective. So we got a lot of things that are happening that are really, I think, going to help some of that. All right?
And I gave you a broad overview of the program. We'll come back and talk more specifically about what happens. And again, I want you to understand, if DSS gets a report of abuse or neglect, and we have a sophisticated assessment process that we go through now, and we determine that that child, there's a safety concern, that's us. We're going to go. Okay, we're going to investigate, we're going to do what we've always done, we're going to open whatever kind of case is appropriate, we're going to go to court if we need to go to court, that's us. If we see a high-risk situation where there's imminence, something's going to happen soon, today, tomorrow, within the next couple of weeks, that's us. We got to get out there right away and see that child, see that family, get a handle on that situation, and do what we need to do. We are not giving away any of the work that we are required to do by statute or by policy. Okay? A lot of folks have had different opinions or didn't understand, but we have not changed any of that. And what Steve was saying earlier about indication rate means that if we're focusing on those cases where there is a high risk or a safety concern, and we see that when we go out and investigate that we are indeed being able to substantiate that in some way, it means those are the right cases where we should be involved, and not the lower level cases that were keeping us busy and churning around but weren't benefiting us or families because they weren't the kind of cases where we really needed to be involved, but we didn't have anything else to do with them, so we kept them. So now we have our network of community providers. When we assess that a case has some risk, not the kind of risk that would normally make DSS be involved, but there is some risk, We now have the opportunity to offer families that previously would have gotten nothing or gotten inappropriate responses from us an appropriate response, a community-based preventative response through our network of providers. So these are cases where we assess that there is low or moderate risk. And if we can go out and strengthen the family, build protective factors around that family, then hopefully this family will never have to come to the attention of DSS for an investigation. That is the intent of the program. And the community contractor's job is to visit with the family. There's different, yes, please.
What does DSS consider moderate risk?
Well, it's a very complicated matrix. I can't give you one definition because it has to do with how vulnerable is the child, how protective is the parent, what is the situation in the home. It's a variety of factors that we have to look at together to come up with an assessment. The intake worker gathers as much information as they can to assess and try to get a handle on what's going on. It's then taken to a supervisor for a second level look to determine what that level of risk is. So moderate risk means something could happen, but it doesn't look like it's going to happen right away. Something very different could happen if we get the family some supports, but there's no one definition because there's no one family situation.
Can you give examples
of moderate risk? Moderate risk would be a school-age child in a family where we think maybe mom may have a mental health issue and she's not functioning very well. Right now they're chugging along okay, but if mom is not stable, something could happen. I mean, that's kind of an example, but there's a million examples of that. But if it's again, we look first at the vulnerability of the child. That's first and foremost. You know, a teenager is much more able to protect themselves or go get help than an infant in a crib. So we have to look at all those factors. But the matrix is very complicated. How many factors do we assess?
There's 43 factors, and it's an evidence-based tool that has been, and the 23 factors are things that you usually see in families that have, I'm sorry, yeah. I'm not used to a microphone. It's an evidence-based tool. It is 23 factors that have been seen or that have been shown to be involved in families that have abuse and neglect. So there's there's all kinds of things that we look at from your baseline to, what's happened before to your socioeconomics to protective capacity, vulnerability, all that of each person. But it is based on the vulnerability of the child, and it is hard to just sit here and define what one is or one's not.
And it would be dangerous to do that.
It would be dangerous to do that.
Individualized assessment.
Right. So we want to have, and you're going to get a reporter doesn't always know all the information. So, you might get a reporter that it sounds like it's nothing. And so you get out there and you find out it's more. And the community providers, when they get out there, they do a safety assessment immediately. That's the first thing they do. And if there's a safety threat that's involved, then that comes right back to DSS, and then we go out. So we've got some safeguards in place about that, so that if it is something that it sounded like nothing, or there's the other side of that too. We had a case in one of the counties that was blood and guts, and the school was calling, and everybody sounds like they're about to die and all that. We get out there and some kid has taken an eraser because they're bored in class and scraped their arm up, sit there, and she showed us how she did it and made the marks but the school was freaking out. So, you get out there and you find out, or there was one that was blood and guts, we got out there and she didn't even have kids. So, reporters are sometimes accurate, sometimes not. You never know exactly what you're getting with a reporter. Sometimes they know a lot of information, sometimes they don't. So it is hard to just sit here and say this is a moderate risk case. I tell people in child welfare, it depends. And 2 plus 2 doesn't always equal 4. Sometimes it equals 15, sometimes it equals 20, sometimes it equals 4, but sometimes it equals 2. It's not you can't just, it'd be nice, it'd be great if we could equation it out, but it doesn't work that way. Human behavior is different. You can't predict human behavior. When I was a therapist, I used to tell folks, you know, I don't think Elaine's going to go out here and shoot anybody. But if the right circumstances happened, she might shoot me on the way home, who knows? But, you know, if the right circumstances happen and just the right way, she might. And, you know, you can't predict that behavior. It's something you don't expect, but sometimes people do weird things. Humans are humans. They don't do things logically like we would love for people to do all the time. So does that help?
Yeah.
Sorry, I'm not going to give you a direct answer.
But I will say this, that as we have implemented this past year, we have spent a lot of time in communication with our providers, weekly phone calls when we got started, monthly face-to-face visits, and that's part of what we're doing, is talking about cases. And did this one really make sense when you sent it over, and what did we see when we got, because it's always a learning process for us as well. But child welfare, no two families are ever the same. They may have a lot of the similar presentation, but no two families are alike. So we can't give those kinds of definitions as much as our staff would like to have a definition too. It just doesn't work that way. But good question. So anyway, back to our providers. They assess the families, do a thorough assessment about safety and then service needs. Then what their job is to make sure that families get connected to necessary services and help them understand why that service might benefit them, and work with the family to let the family say, this would really be helpful to me. That's the kind of thing that DSS workers traditionally have not had sufficient time to do. So these folks, the intent was they would have smaller caseloads. We kept them really busy at first, but they also visit more often in the home, and it's a friendly visit because they're not investigating. And they're not looking for reasons why we may have to take the family to court. They really are there to say, we want to strengthen your family, we want to support you, get you help that you need, and then we want to get out of your way, and you never have to knock on DSS's door. So that's the purpose of our providers. And they're also, while they're out in the community, clearly they're identifying families need X, and it's just not here. So we need to work together with our other community partners to develop X, whatever it is, so that families in our community can get meaningful support and assistance. And this is part of what we're talking about too, these ongoing conversations with our contractors. And this is especially what we want to do going forward. This past year, we've really been busy getting the program up and running and understanding what it is and what it looks like. And as we move forward, we really want to get more fingers into the community, the broader community, to say this is what we're seeing, this is what our families need, we now know what we have, what we don't have, and to work together with our communities, the whole community, to develop services that we need to build those protective factors in our families. Certainly, more families are getting more services than before, because these are families, again, that traditionally we would have said, no, sorry, we're just going to say there's nothing we can do for you, good luck, and hope we don't get a call on you 2 or 3 months from now because you don't fit our rigid criteria for services. And now we can say to those families, this is something we can offer you. It is voluntary. Families have to agree to the services. If they don't agree to services, we still have that feedback loop where folks can say, they said they don't want us, but we're still worried about this family. And then once again, DSS can take a look and see, do we need to do something more coercive with this family if we really have concerns and the family's just not willing to work with us. But that's not what our intent is. Our intent is that families can be engaged voluntarily. And of course, what we want from our community partners and our partnerships is that children are safer, families are healthier, because there's a whole lot more folks working with them to give them what they need and to support those families. Please.
Another thing the research shows is that, and if you think about it in your own life, if I come to you and say, you've got to do this, I don't know about y'all, but I'm pretty oppositional. So if you tell me I've got to do something, I'm going to probably push back some and say, no, you're not going to make me do that. Research has shown that in all of these where providers are working with families, that families are much more likely to go to services and make behavior changes because it's not a forced thing. It is something that they are voluntarily choosing to do, and because of that engagement, and they're able to do it because they want to or feel like they need to, not because somebody's saying you've got to, because we're going to take you to court, and if we take you to court, you might lose your kids. Then, you know, that's a whole different thing. We're trying to get even our own staff to not be so coercive and not be so policeman-like, I guess, and really do more family engagement. But this really is family engagement, and it is. The research does show that people are much more likely to go to services and make those behavior changes if we ask them to do it than if we compel them to do it. So that's another reason that we feel like it's going to really be a successful program. And as far as the rollout, if you know anything about implementation and the NERN, the National Implementation Resource Network, you know that to get a program up running with fidelity, it usually takes anywhere from 3 to 5 years. So we are a little over a year and a half in the upstate and just over a year in other parts of the state of implementing this program. So are we doing it perfect? No, we're not. I'll be the first to say that we're not doing it perfect in every place. I wish we were, but we're not. We're still learning. We're learning. We're seeing people make their decisions, and maybe it's off a little bit or whatever. We're making better decisions, but we're still not where we want to be to get the exact right decision every time. So, you know, it's a learning process, and that's why we've got these safety nets and have the conversations like Elaine was talking about, and being able to work together to make sure that children are safe. And that is our #1 priority. Again, if you don't remember anything else, safe children is our #1 priority. I don't ever want to put a child in harm's way, either by something we do or something that we don't do.
And this is what we've been talking about with community-based prevention services. It is a different relationship between the person knocking on the door than it is when DSS knocks on your door. These are folks that are truly saying, I'm here to help, and they don't even have to say I'm from the government because they're from nonprofit agencies most of the time. So they can come in with an approach of, again, people are worried about you. We have concerns about your family. How can we help you? And that's a very different approach than the DSS approach, and allows for an entirely different kind of relationship to build between that worker and a DSS person going into the home. And again, we've been talking about the importance of protective factors. We have to first understand what those protective factors are if we want to build on a family's strengths, and to understand the effects of trauma on a family. We need to understand what kind of protective factors that family is bringing to us as we develop our work around these issues. Because if we're trying to help a family who's dealing with some trauma and we haven't stopped to identify what kinds of protective capacities we have, we're just floundering around still. Because if a mom, like we mentioned, the mom who might have mental illness, if she's not on medication, if she's not stable, she's not very protective. If she's on her medication, if she's stable, if she's engaged in treatment, she might be very protective. But we have to understand where that parent is as we build the rest of our work around the family. And there's also a balance between trying to mitigate risk, to lower the risk level, while we're also promoting a family's well-being. We have to keep those two always in balance, and that's what Steve is saying. We're always going to err on the side of safety. It's not just about building a family up, it's also ensuring that they're getting stronger and keeping kids safe. And if there's a safety issue, we always, always, always have to come back and look at that and address it.
Does that community-based provide goals for that particular family?
Absolutely. Keontae, would you want to address what kind of goals, how you set up goals for a family, a service plan for a family? And you want to, here, I'll invite you on up. It's one of our providers. Come on up. We won't make you do the rest of the presentation, but that's a good question to ask about how do you set goals.
Thank you, Angela. We actually use Angela. But yes, each one of the families that accept services, we develop a case plan. We have 30 days to develop that case plan. Within that 30-day time period, that allows us to visit the family multiple times to get to know the family to find out what those needs are. The case plan is developed in coordination with the parents and any other supportive family member or whomever that they have involved. And at that point, once they reach out to community partners, they should be sharing with you the case plan goals if it relates to you, you know, of course. But yes, all of our families have a case plan, and for the lower risk cases, we're in there providing services up to 6 months, and for the moderate risk cases, we're up, that's up to a year. So again, with those case plans are reviewed every 90 days. I'm gonna call Trina up here in a minute. Yes, ma'am. Okay, the question is if another agency is already providing services and we begin working with the family, do we include that other provider's goals on the case plan? We definitely try to coordinate if we know about the agency, but yes, we try to coordinate because the goal of the program is to for all of the partners to work together and for community linkage. So again, we definitely try to include that, and I'm sure you guys do the same.
Because it takes the community to strengthen the family, and other agencies are part of that. Thank you. Safi is our master contractor for the upstate. Been a wonderful partner for us in our work this past year and a half. Thank you. Yes, Tim.
Elaine, can you talk about the confidentiality with regards to community-based preventive service? Because sometimes I've had therapists that have called me as a parent and did tell the provider that, you know, this has occurred, and the therapist says, well, I'll call, make a report, and obviously the DSS didn't take the case.
I'm trying to make sure I understand your question.
So when we refer at InTech to community-based preventive service, and the provider goes to the home providing that service, but the provider doesn't know that there's a therapist involved, and the therapist was going to make a report. If there's that lack of communication, the therapist has called, or the community provider has called and said, DSS didn't take the case, why didn't you take the case?
Mm-hmm.
You can't really.
Right, well, the provider can call DSS and ask, how did you dispose of the report? They can, and our answer would be, we screened it out, essentially. But that would be part of a provider's important task, is to find out who is the family connected to. So if that's a missed element, I hope that's not a frequent kind of thing, Tim, because that would be critical information for a provider to know that someone in that family is engaged in therapy somewhere. So I would hope that that is something that would typically come out as part of an assessment. And again, from the provider's perspective, this is a voluntary service this parent has agreed to. So some of the confidentiality issues after they get involved are very different than when DSS is doing a coercive service, that the family's giving you permission, essentially, to communicate about.
It sounds like what I thought I heard you said was, like, DSS didn't communicate to you as the reporter, that sometimes we don't know who made the report. So again, once we get involved with the family, because that's part of the beauty of the program, they go, we're not DSS, again, and I know the school made the report, and we go, honestly, we don't know. So again, we try to ask them who's involved in that kind of stuff. Right, so that's what they and it informed you that.
Right, and that's part of the education piece. You're talking about mandated reporters make a report and they think we just didn't do anything. But that's part of the education process that we have to continue to do as we move forward, is to make sure the community is aware of how these folks are connected to us in the work. In schools, we often hear that question from schools when we first got started. Who are these people that are asking questions? And so that's part of the educational piece. Let me get the lady in orange first.
I just have a suggestion, because I'm a provider, and what I always do when I go out is that I tell my community partners that if you call DSS and they say, well, we don't have the case that was screened out, you can call Children's Place. I can't tell you if the family is with me, but if you say I have a concern about this family, then what I can do is, if I do have that family, and say, can you tell me about if you received any type of mental health services, or can you tell me about a support or someone you have in your family? I can't tell you, but I can listen to you. I can't talk to you. You may call me and say, Cynthia, I'll be like, I can't say anything, but I'll listen to what you have to say, because that's confidentiality. So it's important for you to know who's providing that service in your county, and have a relationship with them. If you call DSS and they say it's been screened out, the screened out could be it's no action, or it was referred, or maybe they say to you it was referred, and then you can call, and then always know that it takes different amount of time for our response to you, because we are in the family building that report. And sometimes we know about you, and they tell us no, I'm not going to give you a release. And so sometimes we have to build that rapport and get that trust. But be sure we want to talk to you, and we're coming to talk to you, but it just takes time for that family to trust us, because they still think that we're trying to do a case finding, whether or not there's abuse or neglect or not.
Yes, sir.
What we work out is something like that. As a reporter, you can request disposition of the report, and DSS will call you back, however you want to call that. Most of the time, they'll just call back. You have a 4 hours to make that determination. If it is sent to a provider, we tell the reporter it's sent to this provider, and here's their phone number. So if you don't call back and find out what's going on.
So we can help facilitate those connections. Yeah. 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 Okay. Any other questions? Okay. All right. So what do we hope to see? If we're doing business in a different way, what is it that we hope we're going to see going forward? And the primary thing, and this is also something we're really trying to work hard with within our agency too, is we've got to put families at the center of this work. That's why we have the work, is because it's about families. And we've tended in the past to make families sort of the problem, but not the center of the work that we're doing. So this is an attempt, again, to give families engagement, support, meaningful support, and relationships that put families back at the center of our work. We want to reduce stigma and labeling of families. Just because a family is struggling and there may be worries about a child doesn't mean they're an abusive family or a neglectful family. Sometimes they're just a family that's struggling right now. So this, again, is an opportunity to give them services that says, we're here to support you. You're not a bad family. We're just here to support you. So it's a different way, again, for families to hear from agencies about the work that we do as well. And we've talked about this before. Families are diverse. They need different kinds of responses. The lovely thing about having these services stem from local communities and not somebody from Spartanburg serving families in Oconee County, that these are providers that are part of our communities and provide services anyway, so it connects us back to the communities. And the same thing, removes the distance between professionals and families, the distance of psychological barriers about what my role is with you, and also, again, these are folks that are in and of our communities anyway. And it builds a partnership between the professionals and the families, and that's essential. And that's been a really nice piece that's come out of this. We've had some tough stuff to work through. We've had some great moments and things that we've seen, but it is truly a working partnership with these providers, and that's a really great device for being able to move us forward in the future. And everybody has a role and has something to do in working with these families. All right, that's you.
The other thing that I want to say is, in typical DSS fashion, a lot of times when you have a problem family, we don't recognize the strengths of the family. We tend to go, and that's not just within DSS. There's like a lot more negative words in our vocabulary in the English language than there are positive words. And so we are not real good at looking at people's strengths. And so even families that are struggling have strengths that we can build on, and but we got to find those strengths, and we've got to be as intentional and as forensic about finding those strengths as we are about finding the negative that goes on in families. So that's one of the other things that we're really working hard about doing with both this program and within our own staff, is looking for those strengths in families to build on instead of looking at all the deficits in a family. It's easy to see our deficits. It's not as easy to see our strengths. If you don't believe me, just pay attention when you're talking about somebody. You'll talk about, oh, they got that bad hair day, and look, did you see what they were wearing? I mean, you see all that kind of stuff when you're talking. You don't say, hey, really, they look good today, and all that kind of stuff, hardly. All right, so what we're doing is we've changed to decision-making tools and processes that are different, and we've talked a little bit about that. And we're looking at more of a teaming approach. We're not looking at families as the enemy. We're not looking at families as somebody that's below us. We're looking at how we can team and work together to increase the protective factors and the protective capacity of each family and of each community. Because each community has strengths and weaknesses just as well, right? I mean, some communities have a lot of services, a lot of things they do. Some communities don't. They have some gaps in service that really need to be enhanced. So we're looking at that collaboration. We're looking at how we can build the protective factors within each community. And one of the things I want you to think about is, within your community, where are those protective factors? Who does child development? Who does the social supports? Who does the child care and developmental stuff? Who does your your social connections? How do people do that? Or are you lacking that within your community? We need to do more protective factors training for parents about what are protective factors, what are developmental stages, like I said, what's an appropriate discipline for a 2-year-old versus a 17-year-old, how can you do that? And giving the other thing, and Elaine and I were talking about this coming down, we need to get our parents more involved in giving us feedback about what has happened with them, what they've seen, what they've been able to find, whatever they need, so that we're getting some feedback in our continuous quality improvement about how we can help them or make improvements in the way we do business. We want to continually get better, not go backwards. So we're looking to continuously improve our product or our way of dealing with families and getting them strengthened, so that, there's nothing I would like better than to be able to stand up here in 5 years and say DSS no longer exists, because there's so much prevention going on that there is no child abuse. Wouldn't that be great? All right. So, and this is what we've been talking about, you can't just assess the risk. You can't just look at a family and say, wow, they got this. You've got to look at the whole family. How is their protective factor? Their protective factors, their protective capacity, how is it enhanced? Where is it lacking? Is this risk something that really puts this child in danger, or is it something that just makes it, where they need some services that would help and that will build the family up? And we talked about doing our case planning and all, and one of the things that we have not done a good job with, where it says engage courts, judges, attorneys, and other staff and CASAs, we've not done a great job of explaining all of this to the community and to everybody that's involved. We need to do a better job. We did a pretty good job at the start with our first 3 counties that we rolled out. We actually went and spoke to the judges and told them what was coming, and I know Keontae and Keith did a lot with the schools, and I'm sure, Katrina, y'all have done some stuff in community. I know you have with, Growing Homes is our other master contractor, and they have, Safi has the upper part of the state, and Growing Homes has the rest of the state as the master contractor. And so we've just got to do a better job of getting out there and letting folks know what's going on, and so that schools and other people, when they make these reports, they understand that just because somebody's not coming to school every day on time, or they're dirty or something, that might not be a DSS case. We've trained people that that's a DSS case, but maybe it's something that's going on that can be just some services provided would really help that, and that will strengthen that family, and they don't have to be involved with us. So we've got to do a better job of educating the community ourselves. That's something that I didn't do a good job of making sure we did that as we roll this out throughout the state.
Okay, so we're going to give you a challenge walking out of here today, and that's for you to do some thinking about what in your community, the place where you work every day, what is it that we need to do to build protective factors? What's missing? What's working well? What can we do to pull those things together? Who's missing from the conversation? Because if we build protective factors within families, then we will be seeing less of them over on the DSS side of the world. So you folks are important people in your communities. You're here today at a prevention conference. Obviously, you're interested in the issue of prevention. This is a great opportunity to go back and have some community conversations and assessing where are we today in terms of building protective factors in families. Where do we want to go, and when do we want to get there? And how will we know it when we see it? We're going to continue providing the services that we're providing now through our community-based prevention services partners. DSS will continue to do the work that we've done around ensuring that children are safe and intervening when we need to, but there's a giant gap in between of what we need to do to strengthen families and to build parents up so that they can ensure the safety and well-being of their own children. So this is a conversation for you to take back. Anybody have some general thoughts about this large issue, how you might get started? Where would you want to get started? Yes. I would bring you a mic, but I'm.
It's been like a year and a half. So what are some commonalities that you're identifying as some gaps? Like what are some things that are what are those gaps that you're identifying?
Would you mind, you and Katrina?
In general, but you can.
Katrina, you want to come up and jump in on that conversation too? We got about 5 minutes left, so what have you not had?
I love my upstate people. Some of the gaps in services, I'll start with the school district since you guys are with the school district. There's still some communication barriers there. Although we've been involved a year and a half, and you know, we came out and spoke with you guys and all this stuff, it still seems to be a difference throughout the different school districts. It's not our policy to typically go to the school and talk to the kids and all that, because again, we're not DSS. But at the same time, if the parents have identified and that they need some help with school and we want to talk with the teachers or whatever, and we have that release and that kind of stuff, sometimes when we go to the school, they're still like, who are you, what do you want? No, you can't speak to anybody, you know. So again, we still need to work a lot of that out. And I do know we had that most recently when school started. And you guys may know Charlene, she's the program director. She's actually working with Kenneth to kind of work on that in regards to letting them know, you know, again, reminding maybe some new people within the school district, you know, who we are. So again, that's one of the barriers that we do see. There's still some transportation barriers that we do see where families can't get to the services, particularly out in the rural areas. And of course, in those rural areas, they don't have the resources available. So again, we still see some of those as well. And let's see what else. I can't think of any, but they're like I said, we do, and also trying to find services for kids that are not daycare, so like 11. So even, you know, the after school, that kind of, because kids get in trouble. So we still see some gaps in services there, and we try to be creative and trying to figure out things for kids to do during that time frame. But that's also some of the areas that we're seeing as well too. You guys see anything different?
Well, I'm the same thing tonight.
Oh my God, I forgot about the camera. I forgot about the camera.
For the other areas, I mean, I would tell you that there are certainly gaps in services just in terms of resources in general. I mean, she mentioned transportation, but just services in general for low-income families who can't pay by sliding scale, who don't qualify for Medicaid or don't want Medicaid or any other services or any other assistance for services. When you talk about barriers, I will tell you, for many of our administrative professionals, and I'm talking about judges, I'm talking about the courts, I'm talking about people that have positions that don't really understand this level of work, that want to require families to go through a voluntary service. Clearly, it's a lack of understanding and a barrier to us really working with families. Law enforcement has been a help. I haven't seen them anywhere in terms of being a barrier. So as we talk about strengths, I really want to talk about things that we've seen working as well. So we've gotten, we've talked to some Head Start folks in our communities. We've talked to law enforcement in our communities. We've had conversations with some teachers in our communities as well. So there are opportunities to talk and share and get really the buy-in from the community about the service. Because again, when a therapist or a teacher makes a report, they really want to know what is going on. And without consent, we really can't talk about that. We really can't share that type of information. So going from county to county, really letting them know what this service entails, and that we really want them to understand that it is not us being rude, but it is a part of the service provision to really get consent from families. We want the families to begin to trust us enough to share who additional providers are in the household with them, or to share those things that would have not possibly come out in an investigation. Because it's not what we're doing, and so we really want to approach this whole service in a totally different way. So that's my input, I would say. But it's been a year and a half almost, and there's lots of work in progress. But there's been learning and there's been growing, and we really appreciate what's happening right now with this program. It's probably the best thing that DSS has been able to do for the communities and families for South Carolina for quite some time. So,
one more question, lady in the back.
No, I just really wanted to say one of the biggest barriers we see is poverty.
Oh yeah, that's
it's pervasive.
right.
And it's really hard to actually address. It's not neglect, it's not abuse, but can it really devastate a family, and trying to find enough resources to help a family that is truly poor in this state is really hard.
That's true. It's true. Yes.
Have you had any success and engagement in faith-based communities in helping providing resources for any of the families faith-based involvement in the programs?
We actually have made connections with like local churches, like for the use of the facility. So again, on a small level, what we haven't, and of course, with some families who are involved heavily in their churches, and they allow us to pull again from those resources, because if they have identified, a pastor or something like that, or someone within the church as a support, then we reach out to them as well that way as well. So.
One great thing I think about churches is their willingness to give. So we've been able to get grant funding from a local church in our community that has been helpful in this work. I think we do use some sites for different trainings and such like that. So we have been able to get them involved to a degree in this work.
We are seeing, we have several churches in the upstate, because that's all I can speak from, who have reached out to DSS in general and said, how can we help foster parents, to support foster parents? How can we support children who are in care? And we're having that ongoing conversation. We're having a conversation with one of our congregations right now about providing chaplaincy services to DSS staff who are often traumatized by the work that they do. So there are many interesting conversations happening with the faith-based community right now, but there's always greater potential for that. Yes, this has to be our last comment.
No, it's not a question, just a comment to share with her, and I live in the upstate as well. The church I attend began as an adoption and foster care ministry, and it's been well attended. It's to help to increase the number of families within our congregation who will become foster parents, and had someone from DSS who came out and gave a great presentation, and they've been very successful even within about a 2-year period, not only to create an awareness of some of the need, but then to actually increase the number of families who are willing to take on this role and provide them the social connection that they need in order to be successful foster parents or adopters.
Absolutely, that's been a beautiful partnership. So that is one of the places we certainly could start with our X to Y by when is to include the faith-based community in that conversation. So we have run out of time, but I really appreciate, oh well, we can have a couple more. Does anybody else have another? Yes, okay.
I just want to share that I have been working with Empire Families with one of the caseworkers there, which we have established a relationship, and we've been collaborating together, working with some of our families, and that has worked. I think we have good communication with one of the partners or whatever. Because I work at Anderson Behavioral Health in the Anderson County, and so we work together on some different parenting issues or whatever. The only thing I get frustrated with her about is when she does not communicate with me that she has closed that case.
No.
And I have not finished some of our goals as we work.
Okay.
So I think that's just something.
That's some good feedback to make sure that if we have engaged other partners. Mm-hmm.
Yeah, I've been coming into play with some of they closed their case, they told their family it was over, and I have not completed all of our paperwork and closed the goals that I thought we still need to work on.
Okay, but
Because we're done, don't we?
right,
And we have that sort of
Right.
all the other
Right.
families let us continue with, and that's a good thing.
Right, right.
And I'm just saying, I think sometimes it would be great for us to maintain this.
it's good to know who else is involved in case you do need to communicate. Okay, that's good feedback. Good feedback. Okay, did someone else have? Yes.
With the fast-growing Hispanic community, how are you reaching out to those families that a lot of times are coming with no education or no education? How are we reaching out to that through your services?
Mm-hmm. And I'll let the providers speak to that. I know that DSS is always on the hunt for qualified bilingual casework staff, and that's a struggle. It's a struggle for us. And of course, we always provide interpretation services. We can always get a contracted interpreter, and we do provide that service.
Yeah, that's what we do when we utilize these people who don't have the bilingual staff person, but we do utilize definitely interpreter services if they're the interpreter at the same company with the case manager or the business.
So are those numbers high, or they're steady, or?
They actually were the number of, well, I don't know, I haven't looked at your data so much lately. For DSS perspective, we were starting to see an increase, and again, I'm more familiar with the upstate. We were starting to see an increase back in 2010, 2011 when the economy went sour. That population seemed to diminish, whether it was just not coming to our attention or whether folks went on to other places in search of some income. So it's really kind of stabilized right now. It's not a large growing population, but it is essential that we communicate appropriately with those families if we're going to meet their needs. That's a challenge. Okay, well, we will let you go, folks, go now, because obviously we're a little past our time. Thank you so much for coming today.